On today's show, we're discussing obesity and a controversial new framework that is challenging how clinicians diagnose it. This is the JAMA Medical News Podcast. I'm News Director Jennifer Abbasi. Associate Managing Editor Kate Schweitzer is here to talk about her story. Kate, thanks for joining.
Thanks, Jen.
So tell us, why is defining obesity still such a struggle?
It seems pretty straightforward, doesn't it? Well, even though it's a condition that affects more than 1 billion people worldwide and is often described as one of the most pressing public health challenges, there's no single universally accepted way to diagnose it. Traditionally, clinicians have relied on body mass index, or BMI, which is calculated using weight and height. It's simple, it's fast, it's been used for decades, but many experts now agree that it's also quite limited. It doesn't account for factors like fat distribution, muscle mass, or how excess body fat is actually affecting a person's health. We've heard the examples before. Olympic athletes may be classified as obese on paper, while people with Asian ancestry may have a low BMI but carry hidden risks associated with obesity. So last year, a global commission convened by editors of the Lancet Diabetes and Endocrinology introduced a new diagnostic framework to move beyond BMI. But what reignited debate among experts was that it separated obesity into two categories: preclinical obesity and clinical obesity. So preclinical obesity refers to people who have excess body fat but haven't yet developed complications. Clinical obesity, on the other hand, is when excess adiposity is already contributing to chronic disease, things like heart failure, hypertension, or obstructive sleep apnea. In theory, it's a more nuanced approach for a deeply heterogeneous illness, but in practice, critics worry that added complexity could do more harm than good. For instance, labeling someone with preclinical obesity may elicit a more wait-and-see approach and delay care. There's also disagreement over how the framework classifies obesity-related disease. Some organizations, namely the Endocrine Society, have taken issue with the Commission's requirement that obesity must directly cause the health issue. This, critics warn, may result in some patients with type 2 diabetes not being recognized as having clinical obesity, even though type 2 diabetes is one of the most common and consequential complications of obesity.
You mentioned that the new framework aims to move away from relying on BMI for obesity diagnosis. How practical is it for clinicians to actually do this?
That's another major sticking point. The framework encourages more detailed assessments, things like waist circumference measurements, body composition scans, metabolic markers. And yes, of course, these provide a more accurate picture of a patient's health, but they're nowhere near as quick and easy as BMI. Clinicians say these tools aren't standardized and they require more time, training, and infrastructure that's not always available in every exam room. So for that reason, many clinicians continue to use BMI, as imperfect as it is, as their first step. And honestly, that's what feels like the biggest tension surrounding the Commission's framework, this friction between simplicity and precision. The Commission's lead author reminded me that in other areas of medicine, diagnosis involves multiple measures, not just one number. A neurologist wouldn't diagnose someone with Parkinson's disease after seeing just any tremor, he said. A clinical obesity diagnosis would ideally require a comprehensive head-to-toe assessment. Some clinicians I spoke to do this as part of standard practice. They focus less on weight alone and more on how it's affecting a patient's daily life. Still, others question the feasibility of this approach.
What are the broader implications of all of this, Kate? Why does getting consensus on this definition matter so much?
Defining the condition isn't just some academic pursuit. How we define obesity has real consequences. It can determine who qualifies for treatment, what insurers will cover, and how clinicians prioritize care. For starters, it could change how many people are classified as having obesity. One study suggests the new framework could substantially increase its prevalence, considering it would capture those with anthropometric-only obesity, those people with normal BMIs who are often misclassified as healthy despite increased cardiometabolic risks. This rise would have downstream effects on health systems and on insurance coverage and access to medications. And when you consider the increasingly effective yet expensive weight loss drugs that are already reshaping the landscape, those effects stand to be consequential. Right now, there's still no consensus, but what most experts do agree on is that this debate is necessary and that ultimately the field will need to find a middle ground that balances scientific rigor with real-world practicality. Because frankly, without a unified shift in definition, systems-level change won't happen and outcomes for patients won't improve.
Thanks, Kate. All right. If you'd like to learn more, we'll include a link to Kate's story in the show description. This week, we also published a story on the growing popularity of unapproved peptides that are being sold on the so-called gray market and touted for wellness. You can find that in all of our stories at JAMAmedicalnews.com. Thanks to Kate Schweitzer for joining me. I'm Jennifer Abbasi for JAMA Medical News. This episode was produced by Daniel Morrow and Sophia Kesa at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening, and join us again next week.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.